For those of you who are just joining us, welcome to the Society of Nuclear Medicines and Molecular Imaging Annual Patient Education Day for Neuroendocrine Tumors. My name is Josh Mailman. I'm the president of the NorCal CarciNET community and past chair of the Society's Patient Advocacy Advisory Board. We are very pleased to be here with you and thank you for joining us. This is the 9th year that the SNMMI has held this event, and it is the first time it's been done virtually. We are excited about the opportunity to share the latest advances in nuclear medicine in this format, which allows us to reach a broader audience. We have registration, participants, and speakers from around the world. Today's event is put together by the SNMMI's Patient Advocacy Advisory Board, which includes representatives from 14 different advocacy groups, including 2 organizations that offer support for and advocacy for patients with NETs, NorCal CarciNET and the Pancreatic Cancer Action Network. Many of the patient advocacy board members are out there watching this webinar today, and we would like to thank each of you for your help in putting together an excellent program and lineup of speakers. Before we begin, I would like to thank our sponsors. We could not hold this programming without their generous support. You'll find them listed on the SNMMI's website, and many of them have provided patient materials on the site as well. I encourage you to check them out. Our sponsors include Advanced Accelerator Application, Astellas Pharma, Blue Earth Diagnostics, ITM, Jubilant Radiopharma, Progenics Pharmaceuticals. Please note, we will have time to address questions after the sessions. If you would like to submit a question, you can do so using the Q&A application at slido.com/SNMMI-NETS. All the questions are asked anonymously from your phone, tablet, or computer. This webinar is being recorded, and SNMMI plans to place it on their website shortly. One last bit of housekeeping, because I know we do have some physicians and technologists joining us this morning. We are pleased to welcome you to the sessions, but note there's no continuing education credits being offered for these Patient Education Day webinars. I would like to thank all the speakers who gave freely of their time, expertise to help create a truly virtual experience for our audience today. For those of you who want a really deep overview of the treatment experience for PRRT, you may wish to view a webinar that Dr. Hope and I produced earlier this year. It's at bit.ly/understandingPRRT, which is appearing below right now on the screen. I hope you enjoy the rest of the day. Hi again. I would like to now introduce Dr. Elshan Zan from NYU in New York. Dr. Zan and I met last year at the Theranostics World Congress in Korea, and we've actually traveled the world a little bit together in going to various nuclear medicine conferences. And Dr. Zan was so grateful that you joined the NorCal CarciNET community group about a month ago to talk about the experience that you have at NYU imaging and working with patients during the pandemic, and would love for you to share some of what you learned with our group and what you're learning of imaging during the pandemic.
Thank you very much, Josh and the NorCal CarciNET team for inviting me today. It's an honor speaking with you. I had a great session with you a month ago and learned a lot. I really had a different appreciation from a patient's perspective, besides from being a doctor. At the beginning of the pandemic, working at New York taught me a lot because we were dealing with too many unknowns. We didn't know whether it was safe to image the patients back-to-back in the same scanners, how to clean the scanners, how to provide the safe environment. But now I think we are doing a much better job because, first of all, safety first. We make sure that after every patient, after using the CT, MR, or PET-CT scanners, after every patient, we leave enough time to clean the scanners. And this includes the table that the patients are scanned on, the scanners themselves, the bore of the MRI or the donut of the CT. They are all cleaned with appropriate institutionally provided and approved solutions. And at the same time, from patients changing rooms to uptake rooms in case of PET, every room, every chair, every surface that we think the patients may have touched are cleaned in detail. So safety first really means a lot right now. And as much as we try to keep our patients safe, that means that we are keeping ourselves safe at the same time.
I know you have talked to us about minimizing the amount of contact that your staff has with patients with ways to automate and letting patients know to come in. Do you want to talk a little bit about those procedures and even how patients can come in and out with their own mask or masks that you provide during the procedures?
Yes, so we try to automate the workflow as much as possible. This includes every patient to be able to check in before they even show up at the door and receive a little alert telling them that we are ready for them to show up at our registration desk. And we have minimized the contact between the patient and our front desk staff and the time spent in our premises at the same time, because mask is mandatory and we know putting a mask on your face, laying in an MRI scanner, which is a long hollow tube, may be very challenging. I brought one mask here. We provide this mask to every patient for the MRI scanner because this was prompted by our patients coming in with different types of masks with different types of metals in them. And, we don't want any metal on the patient's bodies during the MRI scanners. So this mask is free, it's given to every patient, and unfortunately here we keep it mandatory for the patients to keep the masks on during any imaging procedure. Some patients are not comfortable putting even our lightest mask on, so we help them with providing a nasal cannula for extra oxygen. And so far we have been successfully scanning all of our patients with the masks on provided by NYU. They are single-use, disposable, and after you leave the premises, you can go back to your own mask.
And I know that we certainly had the conversation with Dr. Sunderland previously, so these procedures are going to be different for every institution, but it's very interesting to hear what you were doing at NYU in the midst of the pandemic. So thank you very much for that. And one other thing that I'd love to talk to you about is that, certainly the rest of the day, we're going to be talking about PRRT for NET patients and the use of an approved drug, Lutathera, for NET patients, which has really changed management for many of us. I'm really interested in letting you tell our audience today how you're going about a clinical trial in using Lutathera for another indication and where PRRT may not just be helpful for NET patients, but for other disease states. Do you want to give us a little update on that as well?
Thank you for the question and the opportunity to talk about different versions of diseases where we can benefit from PRRT. Although, as you and I and all of us know, it was FDA approved for neuroendocrine tumors, but that was just the beginning of the game, PRRT game. Right now, we are using it for multiple different diseases. And since at NYU we are leading a clinical trial, I would like to mention that we are using it here for atypical or progressive meningiomas who have failed multiple other treatment lines as a phase 2 clinical trial. So PRRT started as a great help for neuroendocrine tumors, but right now, including meningiomas, paragangliomas, and in some instances, even small cell cancer for prostate or for lung, it's being widely used in clinical trials. So I think we owe you all a big thank you.
Well, with that, I thank you for joining us today and look forward to speaking with you in the future.
Thank you very much, and please stay safe.
Our next speaker today is Dr. Thomas Hope. He's an associate professor at UCSF, specializing in nuclear medicine, a good friend of NorCal CarciNET community, and also a very good friend of mine. Welcome today, Dr. Hope. I know we're going to talk a little bit about the understanding theranostics and imaging and how that works together. I know you and I have done several webinars together, including one earlier this year in April with LACNets. And for those of you who haven't seen it already, that's available at bit.ly, Understanding PRRT, and we'll have that up in different places throughout the day. Thank you so much for joining us, Dr. Hope.
Great. Well, thank you for the opportunity again to talk with everyone about PRRT. And I'm just going to give a very short introduction. This is not going to be an in-depth review of imaging and PRRT, just to sort of get the verbiage down and understand the technologies that we're talking about so that everyone's on the same page during our discussion at the very end. So I'm going to talk about the basics. How does PRRT work? And we're going to start with a discussion of imaging. And I think most patients are familiar with about everything I'm going to talk about, but I just want to make sure we're all familiar with the different devices that we use in a radiology department to image patients first. So this here is a CT scanner. CT scanner gives us anatomic images of patients and actually creates an image by, in essence, shooting photons through a patient and measuring the attenuation. We can also give iodinated contrast during the scan in order to create contrast and see lesions better. These are the types of images you get off a CT scan. In this case, you can see the liver and the spleen and the bone. It's very good for looking at lung and bone. It also happens very quickly. So you can get a CT scan with multiple phases done in something like 5 minutes, as compared to the next technology we're going to talk about, an MR, which takes much longer. So it's a very fast imaging study. There's not a lot of artifacts in them in general. And then you do usually get iodinated contrast, which mostly helps us with seeing solid organ lesions. So things like liver metastases, it's very good at helping image. Now, an MRI looks like this. It's a much bigger machine. It weighs a lot more. It weighs something between 10 and 20 tons, depending on what type of scanner you're talking about. And it also makes a bunch of noise. So those of you who've gotten an MR are quite familiar with the irritating noises that occur during a scan. But it gives you the ability to create different types of images. So a CT scan images density, and MR images something called the protons, so how the protons interact with their environment, their spins, which allows us to get different types of contrast and see things better. And in particular, in the setting of neuroendocrine tumor, MR is very, very good at looking at liver lesions. And so I particularly like this thing called the hepatobiliary phase, which on the left there, you can see the liver is very bright and white, whereas the metastases are very dark. And it's a very reproducible way to image liver metastases over time, which in the setting of neuroendocrine tumors is very valuable because a lot of patients have fairly slow growing tumors, and so having reproducible imaging is important. So MR is another very important way of imaging patients with neuroendocrine tumors. Now we're going to move over briefly to PET imaging, and we're going to start just by talking about these octreotide analogs. And I just like to point out that there's this molecule, it's a somatostatin analog, which is similar to sandostatin or lanreotide, which are cold octreotide analogs that are used to treat both symptoms and prevent growth of neuroendocrine tumors. But you can use that same molecule and attach a DOTA chelator to the side. That thing in red there is, in essence, think of it like a cage, and it binds to radiometals. And we can attach to it gallium-68 and use it for imaging, which is the NET spot or gallium-68 dotatate. And that is used or imaged using a PET scanner. So here's a picture of one of the PET scanners at our institution. It actually looks very similar to a CT scanner, and in all honesty, the majority of this device is actually a CT scanner. And the back half of it, or actually the back 3/4 of it, is a CT scanner. And there's also a narrow detector in there, which is the PET scanner. And so it's sequential. So usually you'll go through and get the PET image, and separately, sequentially, you'll get the CT image. And this takes about 30 to 35 minutes to get a good quality image, and really is one of the most accurate ways to localize tumors in patients with neuroendocrine tumor. Here's an example of a patient with a neuroendocrine tumor, had a small bowel carcinoid that was resected. And in the circle in the top row there, you can see in the middle small lymph node adjacent to the surgical clips, which is clearly avid on the dotatate PET, consistent with metastatic disease. And it's pretty clear that the best way to characterize very small sites of disease like this is a DOTA PET. Now, we say dotatate, DOTA, NetSpot. There are now 2 FDA-approved agents. There's both dotatate and DOTATOC, which are labeled with gallium-68, and soon there'll be a third imaging agent for imaging of neuroendocrine tumor. So sometimes we just call them DOTA compounds, or I like to use the term somatostatin receptor PET imaging agents. But these will work very well for imaging of patients with neuroendocrine tumor. Now, the next thing we could do is we can actually use this same molecule and label it with a different type of radioactivity, a theranostic molecule. So theranostics is a molecule that's used for both diagnosis and therapy. So instead of putting gallium-68 into that DOTA cage, we can put lutetium-177 into it and use that to treat patients by targeting the tumor using that somatostatin receptor. So PRRT stands for peptide, right? That's that DOTA chelator we're talking about, attached to the somatostatin analog. We inject that into the patient, and as it goes into the patient, it will then interact with the somatostatin receptors on the tumor cells and get localized into the tumor cell. Now, that DOTA that's attached to the lutetium, so it's going to carry with it the lutetium-177, or the radionuclide, which will decay by giving off electrons, which will then hopefully kill the tumor cell. It takes about 1,000 electrons to kill a tumor cell, and then the tumor cell will die. So PRT, peptide receptor radionuclide therapy. Now, here's an example of that. This is a woman who had progressive neuroendocrine tumor on sandostatin, who was then treated with 4 cycles of lutetium-177 dotatate. And in this example, you can see that the tumor responded very well. Now, this is not the normal response. We, nuclear medicine physicians like to show these images of very nice responses, but actually, in general, the majority of patients have stable disease after treatment, and only about 15% of patients have their tumors actually shrink. And this overall is a somewhat remarkable response. So don't take this as the average or what you would expect to have a response to PRRT. Now, the main trial that studied this was called the NETTER-1 study, and this study compared lutetium-177 dotatate to double-dose sandostatin. So the white line there is sandostatin, the dotatate is the top arm. And the important thing in this trial as a primary endpoint was radiographic progression-free survival. And what that means is it's the time for patients' tumors to grow, how long it took for a tumor to grow on conventional imaging. Obviously, the longer the time, the better. And you can see in this case, lutetium dotatate had a markedly prolonged radiographic progression-free survival compared to sandostatin. And this led, obviously, to the approval of the drug by the FDA, but also has made it the standard of imaging or therapy in patients with neuroendocrine tumor. There's also follow-up data of that trial showing that there's improvement in physical functioning as well as symptoms from the neuroendocrine tumors, such as diarrhea after treatment, which is very important because some of the other therapies that are used in neuroendocrine tumor patients don't actually have overall improvement in quality of life. Now, I have a quick comment about the idea of a unit dose for all neuroendocrine tumor patients. Here's 4 different patients with neuroendocrine tumor. And I think for patients, sometimes it's good to see the range of disease that patients have. You can have on the left there relatively lower volume disease, all the way to the right side of the image having very high volume disease. But each of these patients receives the same amount of radioactivity that's administered to them. So we give 200 millicuries per administration. Now, one thing that's interesting is you can use this device. This is called a SPECT-CT. Now, of note, there's a lot of drawings around because this is in our children's hospital, so they put it into a forest environment for the kids. But the same device can be used, obviously, in adult neuroendocrine tumor patients. This device has a CT in the back half, and the front half has these 2 heads that rotate around patients that take images. And this device can actually image the lutetium itself to tell us where the radiation went in the body, and we can use it to image patients after therapy. So for example, here on the left side of the image is the pre-treatment dotatate PET, and then we have images taken after each cycle, after cycle 1, 2, 3, and 4, and you can see changes over time in the patient. So for example, in this patient, you can see a very avid liver lesion after cycle 1 that is nearly gone after cycle 4, and you'll also notice that the patient's spleen starts to become more and more intense, and the kidney becomes more and more intense intense. And that's because over time, we are causing treatment to the tumor. And so I find these imaging studies very helpful to track response over time, and also to help make decisions if the patient's starting to develop toxicity, whether or not I'd want to push forward and continue on, because we could potentially see what's happening to the tumor over time. It's also helpful if there's progression during treatment to see whether or not that progression is with somatostatin receptor positive or negative disease. Overall, though, post-treatment imaging is not used routinely in the United States, and it's not absolutely required in any respect. There are certain institutions that use it frequently, such as ours, but the majority of institutions do not use post-treatment imaging to help plan patients' treatments over time. But I wanted everyone to be familiar with the SPECT imaging that you can do to image the actual dose that's administered to patients. Overall, conventional imaging, CT and MRI, is key in following patients, and we use it frequently to follow particularly nodal disease and liver disease. And somatostatin receptor PET plays a large role in staging and in determining whether or not patients are candidates for PRRT. Theranostics is the use of that same molecule, the dotatate or the somatostatin analog, for both imaging and therapy. And with the results of the NETTER-1 trial, peptide receptor radionuclide therapy has become an important tool for the treatment of neuroendocrine tumor patients. So thank you very much, and we'll have questions in the question and answer period at the end.
Thank you so much, Dr. Hope. I want to do one quick follow-up with you, if I could. The unit dosing slide was fantastic, and showing that you're giving the same dose, 200 millicuries, to patients. And what fraction of that is absorbed, or what fraction of that normally goes out through the urine? Because I think one of the things that patients don't understand is, even though you give 200 millicuries, that which doesn't bind comes out, and most of it, well, not most of it, but a large percentage of it comes out.
Yeah, so the amount of radioactivity that comes out in your urine is directly related to your volume of disease. So if you were to administer lutetium dotatate to someone who had a very, very low volume of disease, the vast majority of the radioactivity comes out in the urine, and actually really potentially causes more toxicity, although overall the treatment's very well tolerated. If you have very high volume disease, like in that slide on the right side of the slide, then maybe 80 to 90% of the radioactivity can stay in the tumor in the patient. And I think that's really important to realize, because patients' response to PRRT, not response in terms of shrinkage of the tumor, but response in terms of how they tolerate the treatment, is very directly related to their volume of disease. Because if you have a large volume of disease, a lot of radiation will stay in your body and cause a lot more morbidity, tiredness, pain, nausea, those types of things. So in patients with much higher volumes of disease, we treat patients with steroids to try to prevent any of those toxicities. But yeah, the variability is great in terms of how much comes out in your urine. Is directly related to how much tumor you have in your body. It's a great question.
Well, thank you again for your presentation, and I know that you'll be back with us at least once, and then obviously with the Q&A. So thank you again.
No problem. Thank you.
Our next speaker today is Dr. Heidi Del Rivera of the NIH. Dr. Del Rivera is a medical oncologist and endocrinologist, and she leads the rare tumor clinic at the NIH. Dr. Del Rivera, I've had the pleasure of working with you on many different conferences, as well as visiting you at the NIH. Can you tell us a bit about your program, where we are in the treatment of NETs, and how theranostics plays into this?
Absolutely. Thank you so much, Josh, for the introduction. It is a pleasure to be here with you all. So as Josh say, I am a medical oncologist. I'm also a board-certified endocrinologist. And as you may understand, my area of clinical and research interest is in neuroendocrine tumors. But so we can continue, and so you can learn about our program at the NIH. So let me just discuss with you more about what we're doing at the NIH. So just a few words about the incidence and prevalence of neuroendocrine tumors. As we all know, the incidence of, and prevalence of neuroendocrine tumors has increased exponentially over the last few decades. So there are, as we can see here, there has been already publications based on the SEER database where they describe about what is the prevalence and as well as the incidence of various types of neuroendocrine tumors. As we can see here in adults, it seems that we have an increased incidence of lung neuroendocrine tumors as well as other GI or the gastrointestinal neuroendocrine tumors. But also something that I want to mention here is that we also have an increase in prevalence as well of the pediatric neuroendocrine tumors. And we also see in more and more cases in the pediatric as well as the young adolescents neuroendocrine tumors as well. And something that we can see here is that there is different type of neuroendocrine tumors that we see on the pediatrics as well. Something that I want to discuss with you is our natural history study for neuroendocrine neoplasm. This was recently opened, is open for recruitment, where we wanted to include all ages of neuroendocrine tumors, children and adults. Our goal of the natural history study is that we wanted to understand the biology of these neuroendocrine tumors. We want to characterize the natural history, and it's a longitudinal study, meaning that we wanted to study these patients long term. We wanted to include all the clinical characteristics of various types of neuroendocrine tumors. We also want to understand the different patterns of disease progression. We wanted to also understand why patients respond to different treatments and why other patients do not respond to other treatments. We also wanted to understand more about why patients live longer than other patients that have different type of neuroendocrine tumors. Our goal of this natural history study is that we wanted to study patients more prospectively, in the sense that we wanted to study, as I discussed earlier, long term, but we also want to collect data that has been already done. Patients that are enrolled in this study doesn't necessarily need to come to the NIH. We enroll patients remotely, and we collect all the information without the patient coming to the NIH. As we all know, a lot of these neuroendocrine tumors are associated with different cancer predisposition syndromes, such as multiple endocrine neoplasia type 1, von Hippel-Lindau, neurofibromatosis type 1. So, and we also wanted to understand what is the biology and all those different cancer predisposition syndromes that also place in our risk for neuroendocrine tumors. We wanted to also study the relative of these cancer predisposition syndromes as well, and we can prevent for developing neuroendocrine tumors. We also collected all the clinical and laboratory evaluations as well done on different type of neuroendocrine tumors. Something that we are wanted to understand more about it is patient-related outcomes. At the NIH, we have a fantastic behavioral group which is helping us to understand how, by having a specific diagnosis, affect patients on the personal life, also socioeconomic life as well. We wanted to understand that and see if we're able to help in that aspect. We're also doing a very extensive molecular profile on the neuroendocrine tumors. And we also wanted to, by doing all of this, we wanted to understand if we can develop new therapies, if we can understand more about what endpoints we wanted to do in specific clinical trials. We wanted to understand if by doing this, can we establish screening guidelines to prevent development of further neuroendocrine tumors. So the way it works is like either the patient itself referred to us, or maybe the primary care physician is also referring to patients to us. And what we're doing is we're collecting all the clinical information. We're collecting pathology reports. We're collecting also all the imaging reports as well. In our team, we have a multidisciplinary team at the NIH. We want to review everything as a team. We want to review all the molecular or other previous genetic analysis done. We also discuss all this information as well with the referring physician or primary care physician also caring for these patients. Based on this information, patients can stay on this on the rare tumor protocol. Also, if there is a clinical trial within the NIH that we feel that the patients can benefit from, so we're also going to refer those patients to other treatment trials at the NIH, or we can then enroll them on different sub-protocols that are developed at the NCI. And in this case, as we can see here, my area of interest is neuroendocrine tumors, and I've developed already the natural history studies, as I discussed earlier, for neuroendocrine malignancies. One of the things about neuroendocrine tumors, as you all know, is that they express somatostatin receptors. And I'm sure that you have heard this from other experts on today's meetings, but that's something that we wanted to understand. So where is this diagnostics come from? What we can do in order to improve the outcomes of patients of neuroendocrine tumors. And we all know that there are different types of neuroendocrine tumors that express somatostatin receptors. As you can see in this slide, not only the small bowel or the pancreatic neuroendocrine tumors express somatostatin receptors, but there are other types of tumors that may express somatostatin receptors in which this diagnostic approach could be of benefit. At the NIH, we are also developing a neuroendocrine tumor interest research groups, which different investigators within the NIH has a specific focus for the management and understanding of the biology of different types of neuroendocrine tumors. We have investigators at the NIH that wanted to understand more about the immune microenvironment of neuroendocrine tumors. We have other investigators that want to develop preclinical studies, organoids and PDXs and other cell lines, because that's something that we lack in on neuroendocrine tumors. We don't have enough preclinical models to do drug testing, and that's something that we focus also at the NIH. We have also Dr. Franklin, who is also the head of the diagnostics at the NIH, who have also trials, and I work closely together with him on the treatments of neuroendocrine tumors. But as you can see here, there's different investigators within the NIH in which the focus is to understand more about these neuroendocrine tumors and be able to develop more effective therapies. So since the focus of this talk is about where the theranostic fit in neuroendocrine tumors and what are the current treatment trials at the NIH, something that I want to discuss with you is about the basics of theranostic. What is theranostics? So basically, theranostic means there is a combination of the terms of therapeutics, meaning how we can treat a specific disease or tumor, and diagnosis, how we're able to diagnose or localize a specific disease or tumor. And in this case, for neuroendocrine tumors, we're able to diagnose them by doing this scan. It's called 68 gallium dot scan, and I'm sure Dr. Hope and everybody else today has discussed more in detail about this specific scan and how we're able to treat these neuroendocrine tumors. In this case, with Lutathera. Another name for this is 177 lutetium dotatate. And I'm sure you heard a lot about this today, and you're going to keep hearing more about Lutathera and different application of this Lutathera treatment. But Lutathera is a type of PRRT, which is stands for peptide receptor radionuclide therapy, which is a type of radiation therapy that can be given to treat a specific tumor. And in this case, neuroendocrine tumors, because they express the somatostatin receptors in the surface of the cells. As we can see here, the way this works is that we have the radioactive isotope, which in this case will be 68 gallium dotatate or the 177 lutetium, and that has a targeted ligand that will then bind to the receptors on the cancer cell. And in this case, is the somatostatin receptors. And as we all know, neuroendocrine tumors express this type of somatostatin receptor. As we discuss about the basics of the theranostic, I just want to discuss about the NETHER study. And I'm sure you're familiar of this, or you have heard about the NETHER study. What is the NETHER study? It's a trial that led to the approval of the Lutathera treatment. This was led by Dr. Jonathan Strathberg, as well as other investigators as well, and NET experts in the field. And the NETHER study, it was a randomized study, meaning that patients either receive Lutathera or they receive sandostatin, which is the injections that you receive monthly, either extended release sandostatin or somatoline or lanreotide. And as we know, the investigators found that there was benefit of this treatment with Lutathera neuroendocrine tumors not only stabilize the disease, but also patients live longer with their amount of disease that the patients have. So that's basically what led now to the management of these neuroendocrine tumors, and that has been a very significant step forward on the treatment of neuroendocrine tumors. At the NIH, we have a natural history study for pheochromocytomas and paragangliomas. This is another type of neuroendocrine tumor. What is a pheochromocytoma? Pheochromocytoma is a tumor of the adrenal gland, and the adrenal gland sits on top of the kidney. So these tumors produce excess of adrenaline. And paraganglioma is a tumor that is localized outside of the adrenal glands that also tends to produce adrenaline. It is considered an orphan disease. It is a rare disease. But also we have limited treatment options when they have metastatic disease, meaning when they spread to other areas, it's very difficult to control, and we have very limited treatment options. But another important part about this is that more than 90% of patients with pheochromocytomas and paragangliomas express somatostatin receptors. At the NIH, now we have a clinical trial of Lutathera for patients that have inoperable or metastatic pheochromocytomas and paragangliomas. The PI of the study, or the principal investigator of the study, is Frank Lind. He's a nuclear medicine physician, and I'm the oncologist, primary oncologist, helping with the trial as well. And as we discussed earlier with the studies of the results that were found on the NETHER study for small bowel as well as pancreatic neuroendocrine tumors, we also wanted to understand that by giving Lutathera in patients with pheochromocytomas and paragangliomas, if they can also live longer with the amount of the tumors that they have, and if they can stabilize the tumor. And that's something that we also wanted to understand by giving this type of treatment in patients with metastatic pheochromocytomas and paragangliomas. Another something that we wanted to understand is by giving this treatment is that can also improve the quality of life. Because as you may understand, patients that have excess of adrenaline, they have significant symptoms in the sense that have increased heart rate or increased high blood pressure. And we wanted to understand if by giving this type of treatment can also improve the quality of life and can also decrease the amount of antihypertensive medication that the patient is receiving. Something that I want to explain here is what is the mechanism of action of Lutathera. So as I explained earlier, and I'm sure you have heard that also from Dr. Hope and all other experts in today's meeting, is that Lutathera is a type of radiation treatment. And what radiation do, it can have an effect, a direct effect, meaning that it can cause damage on your DNA and the DNA of the cell. Or it can also cause an indirect effect, meaning that it can cause what we call this reactive oxygen species, meaning that is lacking of oxygen around the cells. And that can also cause inflammation of the cells, and that's another way also for the cells not being able to survive. But another thing that I want to mention here is by doing this type of breaks, so this type of damage in the cells, that can cause what we call a break in the DNA. And we call that single-stranded DNA break. And again, I don't want to get too technical, but I hope you can understand this message because I think it's important. So what happens is that when the body senses that there is a break in the DNA, the body will try to repair itself. The cells will try to repair. So, and in those situations, the way it repairs is by specific enzymes within the cells, and it's called PARP enzymes, P-A-R-P. And again, I don't want to, it's a very long definition of this, but something to keep in mind is that there is a medication that can inhibit those enzymes. And those medications are called DNA repair inhibitors. One name for that is olaparib, but there are other ones as well, like rucaparib. And that olaparib, what it's doing is trying to prevent for that cells to repair itself. And that means that the hypothesis by doing that is that it can potentiate the effect of the radiation treatment, in this case of the Lutathera. There has been some studies, what we call preclinical studies on the cell lines that also explained that the combination of Lutathera and olaparib can be more potent. And the reason why is because, as you can see here, and I just want you to focus right now on the cells that are the blue cells with the little pink dots. So the very first one, the one that say NT, that's the one that is the cells with the neuroendocrine tumor cells in this situation. And if you, on those cells, you give the Lutathera, which is that's the second one, you can see some pink dots. So that means that there was some DNA breaks that is accumulating. And then if we see the third one, we see only the neuroendocrine tumor human cells with the olaparib. And as you can see, you also see a few dots as well. But the last image on that one, you can see by the combination of the two, you see an increase of those pink dots. I mean, an increase of more DNA breaks. And that means that that could be very lethal to the cells. So that's the hypothesis that say that by giving the combination of these two, the Lutathera could be more effective. And based on that rationale, we currently have a clinical trial that is open for recruitment at the NIH with the Lutathera in combination with olaparib. This is a first-in-human study. So we have a phase 1 study that we want to determine what is the best dose and the safest dose of olaparib. And we're going to start with a low dose and then increase the doses up to 300 milligrams twice a day. But we wanted to do what we call a dose escalation trial because we wanted to know which dose is a safe to drug to then move to a phase 2 study, which will be the olaparib dose, the best dose of olaparib with the combination of Lutathera. And what we wanted to know is that by giving this combination, could this be more effective? Could this shrink the tumor more? Because that's something that we wanted to understand about Lutathera, because we know that Lutathera is help stabilize the tumor, but we wanted to see that the tumor shrinks even more. So and that's why we wanted to do this combination to see if the tumor can shrink even more. So this is the end of my talk. I just wanted to acknowledge everyone that I'm working with at the NIH. This is a teamwork. I'm not working alone. So we have a fantastic multidisciplinary neuroendocrine tumor team that we work very close together. And at the NIH, like any other NEDx, we care a lot about you. We wanted to find more treatments for you, more effective therapies. We wanted to understand about the biology of these tumors and develop screening guidelines to prevent further development of these tumors. But I cannot do this alone. I'm doing this with you and with everybody that I'm working at the NIH. Thank you so much.
Thank you so much, Dr. Del Rivera, for that talk. A couple of questions. Obviously, you're trying to extend how PRT works in patients and expand where it's used as well with parapheo as well. So these trials that you've said, are they open, and how does a patient contact the NIH, or where do they open?
Thank you so much, Josh, for that. A very, very important question. Yes, so those treatments trial with Lutathera, they're open. So we are accruing patients now. And due to COVID-19, as you know, there were some limitations initially, but now we're able to enroll more patients. And what we're doing is that we are determining eligibility remotely, so patients doesn't have to come to NIH for a screening visit, meaning to determine if the patient is eligible or not. But then once we determine that the patient is eligible, they need to come to the NIH for the treatment.
I also know that treatments that are at the NIH are at no charge if you are selected into that. Sorry.
Yes, correct. As long as the patient is eligible for our trial, the treatments that we offer at the NIH is without charge. And also we're able to travel patients back and forth as well within the United States. If you want any further information, I have my email on the PowerPoint presentation for you to share, and I'll be happy to answer any questions as well. I also, on my presentation, there is an NCT number. So if you Google that, you will be able to find the contact information and all the basics of the clinical trial.
And also your rare history clinical trial does not require travel back to the NIH. That can be done remotely from anywhere around the United States, correct?
Correct. So our natural history study allowed us to enroll patients from anywhere in the world. And also we have with this trial, we're able also to screen patients remotely. So patient doesn't have to come to the NIH, and we're still able to collect all the medical information, pathology, do analysis. And we have two cohort of patients, the patients that come to the NIH and the patients that are in the field cohort, but we're still able to provide the same expert opinion to all of them.
Well, thank you again, and I look forward, you will be joining us in the Q&A a little later this afternoon. So again, thank you for this wonderful presentation.
Thank you so much, Josh. And one thing I wanted to say is that you have been so instrumental for the care of neuroendocrine tumors, from the Gallium scan for the be able to be available in the United States, and as well as the Lutathera. And we thank you all, Josh. And thank you as well, the organization. Thank you for having me today.
Our next to last talk this afternoon is really a conversation with Professor Rodney Hicks, who is a director of medical imaging at the Peter MacCallum Cancer Center and a professor of medicine and radiology at the University of Melbourne. I've known Dr. Hicks. I actually don't remember when I first met you, Professor Hicks. I'm trying to stretch my brain for that. I do know one of the most impressive moments of time is when we were at the Fourth Theranostics World Congress in Melbourne in 2015, and you walked me through your facility and showed me really one of the first PET machines that was in Australia. Do you want to give us a little history of where nuclear medicine has come in Australia as we talk through our afternoon of PRRT?
Yeah, for me, involvement in neuroendocrine tumours goes back over 30 years. I was very fortunate to do part of my nuclear medicine training at the University of Michigan, where they developed MIBG therapy and scanning, which was primarily for Pheochromocytoma and Paraganglioma. But in the early days, there were some patients with carcinoid syndrome who were treated with MIBG, and I initially started using that therapy for the treatment of the patients, the rare patients that we were seeing in those days with carcinoid tumours. Early on in the 90s, I read an article by Eric Krenning and Dick Queckerboom around indium-111 octreotide, and wrote a letter, which was what we did back in the 90s rather than emails. And at that time, they very graciously wrote back and provided me some indium octreotide, or some octreotide that they'd made in their lab, and we labelled with chemical grade indium that we imported from Canada. And we treated, in fact, my cardiac stress nurse with high administered activity indium octreotide for a gastronoma that she'd developed, unfortunately. And that was in September 99, and we coincided exactly with the month that we put in a PET scanner. And I noted that there was one lesion in her liver at that time that didn't take up the indium octreotide, and because we had a new PET scanner which we'd just installed in 1996, the first PET scanner dedicated to oncologic imaging in Australia. There were two other PET scanners that were primarily used for cardiology and neurology research, and ours was really a clinically orientated PET scanner. And I did a PET scan on her with FDG and found that she had a deposit in the liver that was strongly FDG avid. And interestingly, she had a fantastic response to high administered activity indium octreotide in all of the lesions that we treated, but then progressed in that FDG avid lesion, which was really set us on the path of understanding that this is a very heterogeneous disease, and one that you need to characterize the biology using imaging. Great opportunity to do that. We started using lutetium, again under the auspices of the protocol developed at Erasmus, and with the help that they gave us to develop it from 2005. And so, we now have 15 years experience of using PRRT. In the late 90s, we introduced, based on some preclinical work that I'd been doing in my lab, the combination of indium octreotide therapy with chemotherapy, and this is something that we've continued for many years since then. We have now 2 decades of experience of combining peptide receptor radionuclide therapy with chemotherapy with various agents, which we call peptide receptor chemoradionuclide therapy, PRCRT, to slightly differentiate it from PRRT.
And I know one of the challenges, or one of the interesting things, certainly with thinking about PRCT or PRCT, a lot of this was retrospective data, and I know that you've worked hard, and you and Dr. Hoffman have worked hard on really trying to work on clinical trials inside of this disease state. Do you want to talk a little bit about how ControlNet came about and trying to test these things prospectively instead of retrospectively?
Yeah, I guess we learned very early on that there was a great reticence among the medical community to accept data that was acquired in a non-standardized way as retrospective analyses with some variability in the eligibility criteria and the endpoints, the timing and so forth. The rigor that's normally applied to clinical trials is very hard to do in this disease because of the diversity of the spectrum of disease that we see, both in terms of the tissue of origin. We know, for example, that tumours arising in the rectum respond very differently to tumours arising in the pancreas, which respond differently again to small intestinal neuroendocrine tumours. We also know that there's a wide range of different grades of disease, from very indolent low-grade tumours which are functional in terms of hormone secretion, where the primary clinical problem that needs to be addressed symptoms, diarrhea, flushing, pain, compared to the higher grade tumours, the G3, high G2, where they're truly an oncologic disease, where disease progression is going to limit both the quality and duration of life, where the endpoints that are more traditional in oncology trials and cancer trials of progression-free and overall survival become much more important. But still, quality of life is a very important parameter. So getting that balance and how to do clinical trials in this setting is quite challenging. But nevertheless, it's quite clear that regulatory authorities, who at the end of the day have to give a tick of good health to the data before they're prepared to recommend it to patients and to fund it, more particularly to make it available to patients, we need rigorous data. And from that point of view, rigorous clinical trials is very important. And the only way to do that, we determined very early on, was to do this in a multi-centre setting. And so we've been very active in setting up in Australia a network of centres, all of whom are highly collaborative and were willing to adopt the same protocols across disease groups. For all that, we struggle to get funding because it's a rare disease, and governments and funders often look at what are common diseases. We struggle to get it funded, and at the end of the day, what was previously called the Unicorn Foundation, but it's now called Neuroendocrine Cancer Australia, a charitable foundation which I'm very proud to be a director, came to the idea that we needed to fund this ourselves. And so from philanthropic sources, we funded it at a number of centres around Australia to do a randomised control trial in a specific subgroup of patients with higher grade progressing tumours, who we rigorously characterised on the combination of gallium octreotate PET and FDG PET to make sure that all their disease was expressing the receptors in sufficient number to deliver an effective radiation dose to these tumours, and compared the outcomes in those patients. And that was the ControlNet trial. Unfortunately, that trial is rather small because of the limited funding we've had, and whether or not we'll get conclusive answers to the question of whether chemotherapy or radionuclide therapy are better as the first line treatment, and how patients respond when you sequence them, because in many cases one therapy is not going to be sufficient for every patient and at all times within a patient. And so increasingly, we're going to need to personalise and sequence therapies for our patients.
And I know one of the things, because early on this year seems like it's gone on forever, but early on this year when we were at ASCO at GI in San Francisco, certainly ControlNet gave a first readout with some higher toxicities versus some other therapy, versus what we see in without the combination. But then we're also looking, as you pointed out, with a population that has higher grade disease, and this might be worth the risk or might be considered, because I think, as you and I were talking before we started this segment, we are different. We between locations and what grade we are. This really changes what we might need to do with our disease, and where you might do this with someone with a poorly differentiated or a high-grade NET. This might be different with someone, as you were talking about earlier, with a G1 or kind of low G2. You want to comment about that, how this really isn't one size fits all?
Yeah, absolutely, Josh. As you'd be aware, the current grading system goes into three categories. G1, where there's a very low rate of proliferation, low rate of growth, and these are often indolent over many, many years with or without effective treatment. And the main issue for many of those patients is symptoms rather than progression of their disease. In the G2 group, they can more often be progressive over periods of months to a few years. They're often still secreting hormones that give symptoms. And then going to the G3, which is probably two groups now, really high-grade tumours, which are really card-carrying cancers that need chemotherapy, and an intermediate group which retain many of the features of neuroendocrine cells. They can produce hormones, but they unequivocally grow quite quickly. And we found, and many other groups have found, that the likelihood of getting regression, shrinkage of the tumour, varies across that spectrum of disease. It's actually least in the low grade. The slowly dividing cells tend to be more resistant to the effects of radiation, and the benefit of the treatment is manifest mainly in improving their symptoms. If we look, for example, at NETA-1, the response rate was less than 20% in terms of regression of tumours using CT, which, if we compare the retrospective studies done at many, many centres, and they're very consistent results for patients who were treated mainly for oncologic reasons, for progression of the disease, with more pancreatic tumours and tended to have a higher percentage of G2 tumours, the response rates are in the 30s typically. And if we go to the very highest grade, the G3 patients, and there's now 3 studies, one from our centre, one from Germany, and another from the Nordic, the Scandinavian groups, where the response rates are around over 40%. So the higher the grade, the more radiosensitive they are. But the durability of that response is often less because they're more actively regrowing, and when they start to repopulate, they come back quicker. So if you just look at the simple measure of progression-free survival, it looks worse for the G3s, even though they have the highest response rate. And from but in terms of the benefit to that patient in prolongation of their life, if you compare how long they live without effective therapy versus how long they live when they get an effective therapy, that the difference in the survival is very vast. And so from that point of view, the selection of patients becomes really, really vital in those particular patients, and their benefits, I think, are very different. And so I think increasingly, and I know that this is primarily going out to patients, the very important thing is to understand the goals of care. Are you seeking to control symptoms, to maintain quality of life, or to prolong life? And the likelihood of any of those outcomes is highly dependent on the biology and the characterization of the disease in the individual patient. From that point of view, the balancing of benefit and risk comes acutely into that question. If you're likely to live for a long time and you can control symptoms adequately without increasing the risk, I think you do that. And so we tend not to use aggressive chemotherapy in combination with PRRT in the indolent tumours because the benefits are much less. It's when we get a young person who's got no comorbidities, who've not had prior treatments and have a high-grade and rapidly progressive tumour, the balance between getting an excellent response in that patient and hopefully getting to a point where we can potentially eradicate their disease, not necessarily with this treatment alone, sometimes with surgery of residual masses, but a more aggressive approach, even if it's linked to a higher toxicity, is a balance that I think is worth discussing with the patient and patients considering in that setting. So the CAP-10 chemotherapy, which we know increases the risks of leukemia slightly, is not a good deal if you're going to live for 5 or 10 years with your tumour. And your symptoms can be well controlled by other means. Whereas if the likelihood that you're going to be alive in 9 months is less than 10%, and you can increase that to 2 or 3 or 5 years, then it's actually a very good deal for the patient.
So, Professor Hicks, in the last few moments here, because we're running out of time, but you have some interesting artwork behind you. Do you want to just take us through what one or two of those are?
Okay.
Okay.
I'll take it. I'll take it off the wall. This is a very famous picture of Pierre and Marie Curie that appeared on the front cover of Vanity Fair when they won the Nobel Prize. And I happened to find this in an antiquarian bookshop. It was obviously meant to come to me. It's the original artwork of the Vanity Fair cover by an artist called Imp. So I'm very pleased to have that. And on the other side, there's it's somewhat immodestly a picture of me contemplating my brother's PET scan. Unfortunately, he had a head and neck cancer, and I did his PET scan because it was an unknown primary. We found it, and I'm very pleased to say now 4 years down the track, he's cured of his cancer as far as we can tell. The last thing about that painting was it was done by my sister-in-law, who's actually quite a well-known artist here in Australia. Has won a couple of major awards for her artwork, and so I'm very proud that she chose to paint me and put me in the context of something that I've been very actively involved with for the last 30 years in the development of PET in oncology. So it's a great memento. My kids are already fighting over who's going to get it when I pass on.
Well, hopefully that's not for a very, very long time. And thank you for all you do for the NET community and for the oncology community and the nuclear medicine community. And I look forward to the time when we can have a chance to sit down and have another pint.
Yeah, absolutely. And one of the things that, has been the greatest pleasure of my life has been getting to know patients with neuroendocrine tumors. I don't know what it is about this. There's something secreted by them that tend to make them extremely nice people. Amongst the oncology community, I have so many friends now. And I say that with all honesty, patients who've become dear friends through the journey that we've had together with them. And for me, helping the community through these kinds of enterprises, through serving on the Neuroendocrine Cancer Australia and talking to groups like INCA is really a great privilege to me, and I'm honoured to do it.
Thank you. I'd like to introduce Dr. Del Passan. He is the founder and director of Excel Diagnostics. Dr. Del Passan and I have met many times at many conferences. Of course, last year we met at the annual meeting where you were presenting the first pass of the data from this alpha trial for neuroendocrine tumor patients, and thought that the results were really interesting and wanted you to be able to present to our patients today. And with that, I'll turn this over to Dr. Del Passan.
Well, thank you so much, Josh. Thank you for the opportunity to discuss our exciting results related to first alpha therapy clinical trial in US using somatostatin labeled lead-212, which is an alpha emitter in patients with metastatic neuroendocrine tumor. So these are my disclosures. I thought that I put together some slides for our audience so they understand why we are looking for an alpha emitter. Alpha emitters, they have a very high, what we call it, a linear energy transfer. In simple language, these are very highly energetic particles that often getting close to the DNA of tumor cells, they can cause double-strand DNA damage. As we know, DNA has two strands, and if one strand is damaged, DNA has the capability of repair itself and essentially replicate the DNA strand that has been damaged. In this case, alpha emitters are so strong that they cause double-strand DNA damage, and therefore the tumor cannot repair itself, the DNA cannot repair itself, and it goes toward what we call it the apoptosis or cell death, and therefore cancer cannot actually recur, and majority of the damage to the tumor cells are irreversible. So our hypothesis is that with these kind of agents, we can actually get very close to cure of this kind of a cancer, because now we have specific receptors that we can reach tumor cells, and then by these alpha emitters that are extremely strong, we can actually cause irreversible damage to the DNA of the cells. So just quickly tell you where lead-212 is coming from. Lead-212 is an alpha emitter. We call it the in vivo alpha emitter. Why? Because when it gets injected into the body, then lead-212 changes into bismuth-212, and bismuth-212 is a alpha emitter, 64% beta as well as alpha. And so in the decay scheme of the lead-212, we can generate lots of bismuth-212 that can do the trick and causing the irreversible damage to the tumor cell upon reaching to the somatostatin receptors. So here we conducted our first phase 1 open label dose escalation trial in US. The study was done, sponsored by RadioMedics, and then it was done at our clinical trial site, Excel Diagnostics and Nuclear Oncology Center in Houston, in collaboration with our partner, Oranomed, who is the provider of the lead-212 labeled agent to us. So the primary objective, obviously, it was a phase 1 trial. We wanted to look at the safety and dose-limiting toxicity of the agent. And then, of course, we wanted to see the effectiveness of the agent when we reach to the effective dose based on our trial. And typically, those escalations are done in a way that we call it a 3+3. And initially, you tried in 3 patients with the initial dose that comes from our preclinical studies that we have done before, and also early dosimetry studies that we have done. And then if it is safe, we add 30% to the dose. We go and enroll 3 more patients and just continue until we see efficacy or we see dose-limiting toxicity. In this case, actually, I'm pleased to inform you that we didn't see dose-limiting toxicity, and we reached to a dose that was extremely effective in our patients, which I'm going to show you a few pictures in the future slides. So the inclusion criteria for this trial was, of course, signing the consent form, patients more than 18 years old, in terms of life expectancy, at least 12 weeks. Obviously, we wanted to have histologically confirmed neuroendocrine tumor that are metastatic or unresectable. And we would do multiple anatomical imaging studies such as CT or MRI to evaluate the efficacy of the drug by RECIST criteria, and also do other imaging studies, including PET-CT scan with somatostatin receptor agents such as gallium dotatate to evaluate the efficacy. The one important thing was that in the phase initial study that we started, we excluded patients with prior PRRT in enrollment. And then, of course, if they were on sandostatin LAR, we would ask the patients to be 28 days off the sandostatin, or if it was short-acting, 1 day prior to the treatment. So here I would like to share with you a few of our patients that they received the effective dose, and we had gone all the way to 4th cohort, multi-accelerated dose 4th cohort. This is one of the patients, 45-year-old gentleman with history of metastatic lung neuroendocrine tumor, which often presented as upper respiratory tract infection, had bronchoscopy and the biopsy, which showed well-differentiated neuroendocrine tumor. Then received surgery and lymphadenectomy, and then subsequently, a year later, was found to have bone metastases, and the biopsy of one of the lumbar spine vertebrae showed high-grade neuroendocrine tumor, actually. And he was started on denosumab, and then again progressed, and then we enrolled him on the AlphaMedix trial. As you can see in the picture on the left, there are multiple bone mets as well as liver metastases, and this patient was on was experiencing significant bone pain on 3 types of narcotic medications, smoking marijuana also for breakthrough pain. And when he came to Houston for imaging, poor him, he was screaming from pain when he was trying to go and lay down on the imaging table. So this patient received 4 injections of AlphaMedix. As you can see on the left, we have the baseline gallium dotatate scan on this patient, and subsequent 4 injections. The last picture on the right shows complete resolution of all the bone lesions as well as liver regions. I have treated more than 1,000 patients with PRRT. This kind of a results with lutetium PRRT is extremely rare to see this kind of a response. And you can tell I was so happy to see this when we used alpha therapy. And this was an example, of course, still early on, we need more patients, but an example of what we were thinking about the effect of alpha therapies. And here at this point, patient was looking for a nice place to play golf in Houston when he came for the follow-up. So this was a great, really, payday for me to see this kind of effect on our patients. And the bone scan also showed the same thing. As you can see, left side is not as impressive as baseline study by gallium. This is, of course, looking at the skeleton only, and only few lesions that are very active are shown. On the right shows the response to therapy after 4 injections. We have also enrolled another 3 patients in the next expansion cohort, and we are seeing extremely good results. 2 of 3 in the expanded cohort also show objective radiological response at this point, and we are in the process of publishing our data very soon. We also have amended our IND at this point, and now the new IND allows us to enroll PRRT refractory patients, the one that they have received prior lutetium dotatate PRRT. They can be enrolled. The numbers are limited, but the next phase that we will go, which is hopefully the registration phase, will allow us to enroll tens of patients in that clinical trial. So we are extremely excited for this, and here are the collaborators from Radiomedics and Excel, Oranomed and Macrocyclic. Rapid team is the one that they did the dosimetry for us. And also we received a couple of grants from NIH for this, which we are appreciative of. That helped us a lot to be able to push this clinical trial forward. So I can tell you in summary that Houston, we think we have a breakthrough, and we are so glad for our patients, and this is a dream come true for me. Thank you so much for the opportunity.
Dr. Delpasan, thank you so much for presenting with us today. One of the questions I think you answered clearly was that patients who have lutetium therapy or other PRTs will be eligible for this type of therapy in the future. I think that was one of the questions that we had from our audience. And so that would be one of the questions that I wanted to make sure that we're covering. And that's correct, that's what we're looking for in the future, correct?
That's right. This is, as you know, this is an unmet need area. Patients who progress on lutetium PRRT, what should we do? And I think this will be an answer for them. And our clinical trial has been designed to allow them to also enroll in the clinical trial. And we would like to have this drug available for patients, for future patients who have progressed on lutetium PRRT.
And realistically, looking at that you're in a phase 1 now, how long will it take until we see a registration trial, and how long do those types of trials take?
Great question. We have requested a Type C meeting from FDA at this point. Actually, request was submitted last week. Our timeline right now is the first quarter of the 2021 for starting the registration trial, which will include both PRRT naive as well as PRRT refractory patients.
And that still takes a while after that. So
again, we are hoping that with the results that we have and the kind of objective radiologic response that we are seeing, we don't need that many patients really. Our sample size right now suggests that we probably, for both protocols, we probably need something like 92 patients, and that is not difficult to enroll. But of course, we need to have follow-up, we need to have safety studies along with this trial. So our anticipation is that in 2 years, this is going to be hopefully going through the regulatory process and becomes available commercially. But in the meantime, we do anything possible to make it available to our patients.
Thank you so much for your time. We will be joined now by Dr. Suki Patta from the Stanford University. Dr. Patta is a thoracic oncologist who specializes with lung nets. And let's introduce Dr. Patta. Hi, Dr. Patta. I know that one of the first times you and I met was when you came to NANETS in 2016 in Jackson Hole. You were, NorCal CarciNET community had granted you a grant to come to NANETS to learn more about NETs, and now you're emphasizing in NETs. So we're really interested to hear about new trials that are occurring in the lung net space. And with that, I'd love for you to take over.
Thank you so much, Josh, for the introduction, and thanks for having me today. And of course, that inaugural meeting for me at NANETS was my start in the lung neuroendocrine world. So thank you for that. As background, well-differentiated lung neuroendocrine tumors, otherwise known as carcinoid tumors, remain an area of significant unmet need for our patients, particularly when the tumor is not amenable to complete surgical removal. As an example, lung neuroendocrine tumors comprise 25% of all neuroendocrine tumors and are the fastest growing in incidence. Despite this, there's only one FDA-approved therapy for well-differentiated lung neuroendocrine tumors, which is everolimus, otherwise known as Afinitor, which is an oral targeted therapy against a cancer pathway known as mTOR. A very exciting therapy has hit the landscape of neuroendocrine tumors known as lutetium-177 dotatate, or Lutathera. This particular treatment selectively delivers radiation in the form of a radiolabeled somatostatin analog to somatostatin receptor-positive neuroendocrine tumors. We know that one of the major features of neuroendocrine tumors is the presence of these somatostatin receptors. And one of the ways that we can assess the presence of these receptors on neuroendocrine tumors, or otherwise known as proteins, is through somatostatin receptor imaging, such as dotatate PET. This exciting therapy has an FDA approval, but the approval is restricted to neuroendocrine tumors of gastrointestinal or pancreatic origin. Unfortunately, this FDA approval does not include patients who have lung neuroendocrine tumors. The reason for that is the randomized phase 3 NETTER-1 trial, which resulted in this approval, did not include patients with lung neuroendocrine tumors. Therefore, in order to assess the activity of lutetium-177 dotatate in lung neuroendocrine tumors, we have designed the following trial, entitled Randomized Phase 2 Trial of Lutetium-177 dotatate versus everolimus in somatostatin receptor-positive lung neuroendocrine tumors. I am a co-principal investigator with Dr. Tom Hope at UCSF. As mentioned in Josh's introduction, I am a medical oncologist specializing in lung neuroendocrine tumors, and am part of the clinical trial group known as ECOG Akron, while Dr. Hope is at UCSF and specializes in nuclear medicine and is part of the clinical cooperative trial group known as Alliance. So this is a collaboration between our two centers. Here is the trial design. First, in terms of patients eligible for this study, there must be a diagnosis of unresectable or metastatic lung carcinoid. We know that pathologic diagnosis of lung carcinoid can be difficult, and we also know that pathologists can use a variety of terms to describe well-differentiated lung neuroendocrines of the lung or lung carcinoid. So we have taken this into account for our eligibility, including any patient with the following terms in their pathology report: well-differentiated or moderately differentiated, intermediate or low grade, or simply the term carcinoid, whether it's not specified, typical carcinoid, or atypical carcinoid, as long as it is from lung origin. One of the second most important eligibility for this study is that the tumor must express somatostatin receptor as assessed by an imaging study known as a dotatate PET scan or other similar PET scan. The patient's tumor must have evidence of cancer progression within the last 12 months. Importantly, we have no limit on prior lines of therapy, including patients who are treatment naive, as long as they meet the above eligibility. Another thing that we were very mindful of in the design of the study is that we included patients who had functional syndrome, such as carcinoid syndrome or Cushing syndrome, and concurrent somatostatin analog use, such as lanreotide or octreotide, is permitted on the study with certain caveats. If a patient is eligible for this study, they will be randomized to one of two treatment arms. The first arm is experimental arm with lutetium-177 dotatate. And this is given IV every 8 weeks for up to a total of 4 rounds. The other treatment arm is the standard of care arm of the only FDA-approved therapy, everolimus. And this is given at 10 milligrams oral daily, which is the standard dosing. During the treatment, whether the patient is on either arm of the study, they will undergo imaging every 3 months and stay on treatment until treatment has completed or disease progression occurs, whichever comes first. The primary endpoint of our study to understand whether lutetium dotatate is better than everolimus is to assess an endpoint called progression-free survival, which gives us understanding how well the cancer is controlled in either of the treatment arms. We will also be looking at secondary endpoints such as response rate, whether the tumor shrinks, overall survival, and of course, very importantly, safety of these 2 treatments. In exploratory endpoints, we're very interested in late toxicities from the experimental arm, lutetium-177 dotatate, and of course, very important to our patients, quality of life. As part of the study, we will also learn more about the dosing of lutetium-177 dotatate. I do want to mention one very important aspect of this study that was something we strongly took into consideration during the design. If a patient does get randomized to the treatment arm of everolimus, at the time of disease progression, they will be assessed to see whether they would be eligible to cross over to the experimental arm of lutetium-177 dotatate. It was very important for all of us when we were designing the study to have our patients have access to this treatment, no matter which arm they were initially randomized to. Thank you for your time.
Thank you so much for that, Dr. Pata. You know, a lot of patients have questions about this trial or about, you know, how to get therapy for lung nets, especially at this moment in time when PRT was not part of the label for Lutathera. And I know the endpoint was PFS, and if I remember correctly, this was not a registration trial. What do you hope to gain out of this trial?
That's exactly right, Josh. So we hope to gain information from this trial to understand whether lutetium-177 dotatate is going to be a good, effective therapy for our patients with lung neuroendocrine tumors, and also to evaluate whether it is better than our current standard of care of everolimus. And so this likely won't result in approval by the FDA, but this will give us a lot of information. We know that the biology of neuroendocrine tumors can be very different depending on the originating organ site of the tumor. And there's just limited data right now for lung neuroendocrine tumors. It's been a variety of retrospective studies looking at this or similar therapies in patients with lung neuroendocrine tumors, or even in some prospective studies in single institutions. But first of all, we want to establish whether or not this is an effective treatment for our patients. So that's one of the things. If it is, then of course we have more data to recommend it, to incorporate it into our guidelines, and also make it easier for our patients to get insurance coverage for this very promising therapy.
Well, thank you so much. And we're going to move on to our next session. And I thank you for being here.
Thank you so much, Josh, for having me. Appreciate it.
Our last talk this afternoon is again going to be by Dr. Thomas Hope, and this is going to focus on the long-term safety of radionuclide therapy for NET patients. So without much further ado, let's bring back Dr. Thomas Hope.
Great. Thank you, Josh. Okay, let's see if we can get some slides here. Okay, so today I'm going to briefly talk about radiation safety with radionuclide therapy, and obviously particularly how it relates to Lutathera. And the idea here is to discuss radiation safety in terms of exposure to patients and those around them, and how to minimize radiation exposure. So first thing I want to do is compare external beam radiation therapy to targeted radionuclide therapy. So many patients might be familiar with external beam radiation therapy, where you have actual gamma rays or radiation beams sent through you to treat tumors in your body. And with this approach, there's actually no toxicity outside of where that radiation is aimed at, and the toxicity is only caused by the radiation that's deposited when the beam's on. So it's very different from targeted radionuclide therapy. With targeted radionuclide therapy, radiation is injected into the patient's blood, and the toxicity is caused by the biodistribution of that agent throughout the body. And the radiation is deposited over weeks, so it's over a longer period of time that the radiation exposure occurs. Now remember, with external beam, after the treatment is completed, after you leave the facility, the patient no longer emits radiation, right? And that patient actually never emits radiation, and so there's no risk of exposure to patients around them or family members. But with targeted radionuclide therapy, after you leave the facility, the patient will emit a reasonable amount of radiation, and so depending on the type of radioactivity that's been injected, that can expose patients around them. So there's radiation safety concerns with targeted radionuclide therapy that don't exist with external beam radiation therapy. So to understand radiation safety, you have to understand units. And units are very complicated in nuclear medicine, and I think it can be very confusing both for patients as well as providers. So let's start here with the idea of a millicurie or a megabecquerel. These are units that, in essence, measure the amount of radioactivity decayed per second. So a single becquerel is 1 decay in 1 second, and a millicurie is in essence something like 37 million becquerels, if I remember the conversion correctly. But in essence, it's just describing the activity, the number of times an atom decays per second. Now, you can convert that decay into energy, right? So when an atom decays, it gives off a photon or an electron or some type of radioactivity, and that radioactivity will interact with the surrounding tissues and deposit energy. And you measure that energy in units called gray or rads. Now that gray or rads will then have an effect on tissue, right? So different tissues will have different effects. So for example, your fingernails, if they get exposed to radiation, there's not a lot of living cells in there, so it doesn't matter. But if you expose your bone marrow, which is very sensitive to radiation, has a much higher effect. So the same amount of energy, i.e. gray, can have differing effects on different tissue, which is measured in rem or millisieverts, okay? So what we care about in terms of radiation safety in general is rem or millisieverts, the effective dose that's deposited into patients that can cause issues or toxicity. So we have millicuries and megabecquerels, that's the activity. We have gray and rads, which is the energy that is emitted by that activity, and that energy will cause an effect which is measured in rem or millisieverts. Hopefully as confusing as we can possibly be. Now, let's talk about lutetium, right? When we're talking about lutetium dotatate, or what we use in peptide receptor radionuclide therapy, the radioactivity we inject is lutetium-177. Lutetium-177 decays with a half-life of 6.6 days, in essence 7 days. So every 7 days, the amount of lutetium left goes down by half, okay? Now, lutetium has two types of energy that's emitted. One is an electron. This is a beta negative particle, and it gives off two types of electrons. And these electrons travel a very short distance, about 1 millimeter in soft tissues. And this is the energy that's causing both the toxicity to patients and the efficacy. It's what kills tumors. So about 90% of the radioactivity given off by lutetium is in the form of an electron, and that's going to kill tumors and cause patient toxicity. Lutetium also gives off what we call gamma photons. These are photons that we use to image patients generally. They're in essence like light photons, but with a very high energy. And about 17% of the decay can come off in gamma photons. And these photons are emitted from the patient, and you can actually measure these from outside the patient. And these are what causes exposure to family members and those around patients, okay? So the beta decay is what's causing therapeutic effect and kills tumors, but doesn't expose people around them. The gamma decay, these photons, are what are going to expose patient and family members around, so they actually leave the patient. We can either use it for imaging, but it also can expose patients. Now, let's talk for a second about the risks. So here's a dotatate PET, right? This is labeled with gallium, obviously, but it will look very similar in distribution to a lutetium-labeled dotatate therapy scan. Now, on the patient side, typically the radiation from the electrons will expose the kidneys or the bone marrow. And note that you obviously have a lot of uptake in the kidneys that will come out in your urine. And thankfully, your kidneys are very resistant to radiation, so you don't get a lot of kidney toxicity. Bone marrow, on the other hand, you don't see a lot of activity in the bones, but thankfully, the bone marrow is very, or not, but unfortunately, bone marrow is very sensitive to radiation, so a lot of patients will develop cytopenias, low blood counts, because of this. Now, these are being caused by the beta particles, those electrons. Now, family members will be exposed to two types of radioactivity. One is the emitted dose, so those gamma photons we were talking about that will be emitted from the patient. And that lutetium, again, will give off the gammas and expose family members around. But also, people around the patient can be exposed to urine. So a lot of radioactivity gets excreted in the urine, and a lot of radiation safety is focused on minimizing patient and other people's exposure to the urine. So this is why for men, we recommend peeing sitting down for at least 3 days after treatment. And then also obviously washing hands and making sure we keep the urine away from patients around them, because that urine will actually contain those electrons, which will have a high amount of radiation. But for the family members, we're talking mainly about the emitted gamma rays and then the beta particles in the urine. Now, in terms of the risk associated with the emitted dose, when we started up our PRT program, we measured our first 10 or 15 patients. And I don't know, those of you who've had this treatment, oftentimes you'll see a radiation safety officer come towards you with a meter stick and a Geiger-Muller counter, and you can actually measure the radioactivity of patients emitting. And the measured amount is about 2 millirems per hour at 1 meter at the time of the treatment. And by the time of discharge, that activity goes about down to 1 millirem per hour at the time of discharge. Now, in all honesty, I think most patients would say, what are we talking about? A millirem per hour? Is that high or low? How do I actually think about that in terms of the risks to the patient? So let me try to put this into some perspective. So remember we talked before about millirem is a measure of energy, and millisievert is a measure of effective dose, the tissue effect, right? So you can convert millirem to millisievert. In essence, 100 millirem is in essence equivalent to 1 millisievert. Now, if we look at many types of radiation exposure, so for example, if I flew from San Francisco to New York, I would get an exposure of about 0.05 millisieverts. If I got one chest x-ray, it would be about 0.1 millisieverts. A CT of the head is about 2 millisieverts. The yearly average dose for people in the United States is 3 millisieverts. A CT of the abdomen and pelvis is about 10 millisieverts. So just to give you sort of a range of what these millisievert values mean. Now, if I'm receiving 1 millirem per hour standing 1 meter away from a patient, right? In order for me to get the dose equivalent to a chest x-ray, it would take me 10 hours of standing 1 meter away from a patient to get that dose, okay? So overall, it's not really that high of a dose, but it's important to realize here that time and distance make a big point. So if you are a family member taking care of a patient after PRT, we do talk a lot about radiation safety and we talk a lot about minimizing dose, but just keep in mind that the dose is not particularly high. Again, 1 meter away from a patient who is just treated with PRT for 10 hours, standing there for 10 hours, will give you the equivalent dose of about 1 chest x-ray. Okay. Another thing I think that's important is to take into account age. So this is data here that is really extrapolated from Hiroshima bomb data, which is not obviously in the same range here, but it gives you an idea of, in essence, the relative risk of long-term toxicity from radiation exposure based on age. So on the left column, you can see here, this is per 1,000 millisieverts. So remember, we were talking just before, let's see in the slide before here, we were talking about, chest x-ray is 0.1 millisievert. So this would be equivalent to 10,000 chest x-rays, so a much, much higher dose. And you can see the risk of cancer changes dramatically based on your age. So for example, in patients who are under the age of 20, that risk gets above 10%. The lifetime risk of developing a cancer related to that radiation of 10,000 chest x-rays. And as you get, it goes down quite dramatically until you get to the age of 40. And then after you get over the age of 60, the risk goes down even further. Now, from the exposure of one chest x-ray, you couldn't actually measure that increased risk of cancer because it's such a low amount of radiation. But the point I want to make with this slide is when you're thinking about radiation risk, obviously the younger you are or your family members are, you want to be more cautious with them. So I particularly always make an example of if you have a young child at home, you might want to not have them sit on your lap and read a book for 3 hours right after you've been treated with PRT, just because you want to be extra cautious with younger patients or younger family members. Again, highlighting that 1,000 millisievert thing. Another thing I want to highlight is this thing called ALARA. This is a term we use a lot in radiology and nuclear medicine, which is as low as reasonably achievable. So in our field, we always try to use the lowest amount of radioactivity as possible in order to achieve the either diagnostic or therapeutic effect we're going for. And that also goes with radiation safety. So in general, we as a field, even though we can't measure the effect of the doses that our patients or family members are being exposed to, we always believe that the lower the exposure, the better. And so we give guidelines to try to minimize that exposure, to try to decrease any potential risk, even though we don't really know what the risk is with those doses when they get quite low. Okay, so let's talk a second about minimizing radiation exposure. So when you inject radioactivity in a person, that person will then emit radioactivity around them. There are three major ways to decrease dose to family members. One is time, right? The shorter the amount of time a family member is around a patient who's just been treated, that will decrease the amount of radioactivity they're exposed to. So decreasing time is important. The second thing is distance, right? So if you double the distance you are away from a patient emitting radioactivity, you in essence square the amount of radioactivity exposed. If you get twice as close, you double the amount of radioactivity you're exposed to. And this is a really easy way to minimize dose. And I generally think with a patient, if you're over 6 feet away from a patient treated with lutetium dotatate, in essence, you're not getting any dose. But as you get closer than that, the amount of exposure to a family member will go up. Okay, so if you're in a room eating dinner, you sit at the other side of the table, the radioactivity being exposed to a family member is incredibly low. So maximizing distance will also greatly decrease the amount of exposure to a family member. The last thing is shielding. We talk about this a lot in the hospital setting, but if you were to have something that can block that radioactivity, that will decrease dose. So if you come into the hospital to be treated, you'll see the technologist put up a cart, usually with a lead glass shield to prevent them from being exposed. And that's relevant for them because they do this every day and they want to minimize their lifetime exposure to these treatments. But mainly it's time and distance that once a patient leaves the hospital, you can use these two criteria to decrease exposure to family members. So the take-home points from this talk is, first, radiation exposure from external beam radiation therapy and targeted radionuclide therapies are very different, right? With external beam, when you leave the facility, there's no chance of risk of exposure to family members or those around you. Second, the dose to the patient, which results in toxicity, is caused by the beta emission, these electrons that are causing toxicity in bone marrow and kidneys. Those beta particles don't interact with family members. The gamma emissions, and number 3 here, is what's causing exposure to family members, but the dose rates are very low. Again, to highlight, if you stand 1 meter away from a patient who is just treated with PRT for 10 hours, you as a family member are getting the exposure equivalent to 1 chest x-ray. Now again, in nuclear medicine, we always practice ALAR, or as low as reasonably achievable, and therefore we obviously make a lot of recommendations to try to minimize that dose. And then number 4, I want you to remember the ways to minimize exposure, which is primarily time and distance. Decreasing the time you're around someone who's been treated with PRT and then maximizing the distance. And if you're over 6 feet away from someone who is treated with PRT, the exposure that you're receiving is negligible and not clinically relevant. So you really want to maximize that distance to at least 6 feet or more, and you can be very safe if you do that. So thank you very much.
So we're back live for our Q&A session of the afternoon, and I would like to bring back Dr. Thomas Hope and Dr. Heidi Del Rivera to join me today as we ask the questions that many of you have asked during the day. So hopefully we'll get our first question, but I'm going to do this kind of in segments. There's a lot of questions on PRT, there's a lot of questions on clinical trials, and really one of the first questions is, what, if we look at all the different isotopes that we've talked to during the day, whether it's yttrium-90, lutetium-177, or some of the alpha particles we're talking about, how will we ever know what is best for the patient population, or what type of trials will take to get us there? Dr. Hope, why don't you start us out? And welcome back, by the way. Nice new shirt.
Thank you.
Thank you.
Well, that's sort of a hard question overall, in the sense of what trials will tell us the answer to this question. So I think in general, yttrium-90 is not going to be brought to market in the United States and will unlikely become available. And so in America, the question of yttrium versus lutetium is probably mute to a certain extent. There are obviously sites outside of the United States that use yttrium-90, particularly in the setting of bulky liver tumors, to try to treat larger tumors, those greater than 2 or 3 centimeters in diameter. But in the United States, I think in general, we're going to be a lutetium environment. Lutetium definitely has lower marrow toxicity and renal toxicity associated with it, and so it's pretty reasonable to stick with lutetium. Now, the next question of whether or not alphas versus lutetium, which one is better, I think that we will hopefully find out more as the alpha-labeled dotatate compounds go through clinical trials and we learn about toxicity. It's really a relative value between toxicity and efficacy, and where do alphas sit? Do they go before lutetium or after lutetium? And I think that will really depend on the trial designs and as well as the toxicity rates that we find in those trials moving forward.
So Dr. Del Rivero and Dr. Hope, we do a lot of different blood works beforehand or different markers as we go through our treatments. Is there anything, whether it's CGA or other types of blood markers, that you look at, probably more platelets and things like that are important while one's going through therapy? And Dr. Del Rivero, why don't you start, and Dr. Hope, you can kick in.
Yes, that's a very good question. Thank you, Josh, and thank you to the organization for allowing us to participate on this patient symposium. And yes, I mean, one of the things that, at least from the clinical trial standpoint, we, for neuroendocrine tumors as well, for our clinical trial at the NIH for pheochromocytomas and paragangliomas, we use chromogranin A as one of the biomarkers. Chromogranin A, just to explain, is not very specific marker for because it's positive or high in a lot of different type of neuroendocrine tumors. It's not specific for GI or for pancreatic or for pheochromocytoma. It's a marker for neuroendocrine tumors. One thing to keep in mind is the chromogranin A also can be elevated if you're taking, for example, pantoprazole or all of these medications that helps to decrease the acid input in the stomach. So, and that's one of the things that we need to keep in mind, but that's considered to be a biomarker. It's very highly sensitive for neuroendocrine tumors. The idea is like, how important is this biomarker in order to monitor response to treatment, in order to respond to determine what will be the overall outcomes by doing this biomarker. We're still trying to understand more about this. But again, sometimes it can help us guide us if we need to do any changes in the treatment. For example, another biomarker that we use is the 5-hydroxyndolacetic acid, which is the end product of serotonin that is measured in the urine. And that's also in patients that are patients with carcinoid tumors that produce this serotonin. Or this 5-hydroxyndolacetic acid. And sometimes if it's elevated, that also guides us, for example, to determine if we need to increase the amount of somatostatin agonists that the patient is taking, if we need to add, for example, a sormello to block the serotonin production. So this is another biomarker that also can help us understand more about the functionality of the tumor and if we need to add any other treatments. But again, in terms of following those patients, we do measure these biomarkers. But I understand that there is a difference in opinion about what is the and I can see Dr. Hope nodding a little bit.
I guess the question for Dr. Hope is, is, what do you track just to make sure that you're doing okay in PRT and before you make any other decisions?
Yeah, so I might disagree a little bit here.
Yeah.
I think in general, chromogranin A plays no role. We should not be measuring chromogranin A throughout PRT in any way to address whether or not PRT itself has been successful. I think 5-HIA does have a role, but it probably has more of a role of a pre and post treatment rather than like after cycle 2 repeating your 5-HIA to see where it's at. We have definitely seen patients where these types of blood markers will move up and go up because of a treatment-related effect rather than actual progression of disease, and I think they'd be confounding. So I would generally not recommend many of these blood markers in the middle of PRT to try to determine whether or not you should continue on for treatment. I think for me, the thing with PRT that I use in terms of trying to follow patients is imaging response, seeing if there's clear progression, and also looking at whether or not we do these post-treatment SPECT imaging, looking at the uptake in the patients as they're being treated.
So one of the questions that comes up a lot in patient forums is managing some of the side effects or symptoms that may have during PRT, whether that's hair loss or loss of taste or some other issues that may come up. Do you have any strategies that you use with your patients to mitigate those things?
Well, we have seen some hair loss related to Lutathera. I mean, as Dr. Hope may know, and UCSF will soon be a site for our Pheochromocytomas and Paraganglioma protocol, is that we had some hair loss, but it's not quite significant hair loss. It's not like patients when they receive more of systemic chemotherapy or these alkylating agents that they do tend to lose the hair, but I don't see a significant hair loss. Some hair follicles may fall, but I haven't seen a significant hair loss with this. I don't know what is Dr. Hope's experience with this.
Yeah, well, the question is how to mitigate this. And the answer I'd have is wait till the end of treatment because there's no way to prevent it. It is directly a relation to the effect of the radiation, and there's probably no way to minimize hair loss. We definitely obviously see hair loss. A lot will know that they get thinner. Obviously, I've never seen a patient go bald or anything like that, but it's really more hair thin and hair loss, like you just mentioned. But there's no way, unfortunately, to minimize this issue.
Minimize.
That's right. It's much of having the patient prepared for it, just to know that it's a possibility.
So, and something that I want to add is, yes, completely agree with Dr. Hope. There is nothing that we are able to find that mitigate these. I know that some of my patients, whenever they come, they say, like, can I take these supplements or these vitamins? I mean, again, this is not something that we have seen that had helped. But again, that's like Dr. Hope say, we just need to wait until the end of the treatment, and we have not seen anybody that goes bald with this treatment. Yeah, I agree.
And one of the questions that also comes up is staying on somatostatin analogs during therapy. I know it's part of the label. There's some places that do and some places that don't. Any particular recommendation for this?
The short answer is we don't really know, obviously. If a patient has and it's a hormone-secreting tumor, then obviously one would stay on a somatostatin analog. In a non-functional where we don't have hormones, in general, we certainly keep the patients on SSAs throughout the course of PRT because that was what was in NETTER-1. And after the completion of PRT, should you stay on the SSA or not? And there is no right answer here. So I think in some patients, they really don't like receiving the SSA and they really don't want to continue it. We stop it. In other patients, it seems to be fine. We keep them on it for maybe up to 18 months. It also depends on sort of how aggressive their tumor was going in, what the rate of growth is and their response. If a patient's tumor responds very well, I might be willing to stop the SSA versus something that's been more stable. So again, there's no right answer, sort of more of an art form. And I wish I could say that this is a one-to-one answer of how we deal with SSAs, but it ends up being very patient-specific based on those factors.
So back to imaging, I think one of the questions is always if I'm receptor negative, or what percentage of people are receptor negative in grade 1 and grade 2 and also grade 3?
What percentage of the grade, well, in our experience with the well-differentiated neuroendocrine tumors, what we have seen is that they express somatostatin receptors more than the grade 3 neuroendocrine tumors. And usually something that we have seen is as the tumors tends to differentiate and the Ki-67 goes higher, it seems that they lose the somatostatin receptors. In that sense, they're well differentiated to maintain the somatostatin receptors. They are very avid on the Gallium scans, whereas the grade 3, there's still a percentage of these tumors that may express somatostatin receptors. And it's very important if the patient that has grade 3 neuroendocrine tumor that the Gallium scan or DOTA scan is done, because that way you can determine if this patient can benefit from treatment. What do you think, Dr. Hope?
Yeah, I think that's right. So the vast majority of 1-2s are somatostatin receptor positive on dotatate or dotatalk PET. Grade 3s obviously depends on poorly differentiated versus well-differentiated G3. The poorly differentiated are unlikely to express somatostatin receptors. In the well-diff G3, there's a good percentage that do. I think what becomes confounding there is there's a lot of heterogeneity of expression. And so you have to be really careful about making sure that all of the disease actually expresses a somatostatin receptor, and particularly the disease that's growing, whether or not that portion of the disease is somatostatin receptor expression. In terms of what we do with negative patients, it sort of really depends a lot on your site of origin, grade, and all that. So it's hard to really say the one thing. But the one thing I would say is that Y90 radioembolization becomes much more relevant in patients who are somatostatin receptor negative. That's sort of like one of the big things. In general, we shy away from Y90 radioembolization. But if you don't have any somatostatin receptor expression, that's one of those circumstances where that becomes more relevant.
Right.
I think this is a great follow-up, since Dr. Hicks certainly talked about FTG and versus DOTA gallium. When do you go for an FTG, or when is this important, much as you were talking with grade 3s? Do you want to expound on that just for a second?
This is a hard one. And the reason why it's a hard one is, in all honesty, in all well-diff G3s, I'd probably like to get both. It would be nice to know. Now, whether or not you can get insurance to pay for both is a whole different story, right? And so Dr. Hicks works in a hospital system where he can do as many PETs as he wants, because he's sort of the Australian National Cancer Center. And so there's no reimbursement issues. And that's very different than the American setting. And so it does actually become really hard to determine when you'd want to use an FDG versus when you'd want to use a gallium. Obviously, in the setting of whether or not you're considering PRRT, you would be prioritizing a gallium. If you're post-PRRT or are considering or treating a patient with CAPTEM, carbotopicide, some sort of chemotherapy, then maybe an FDG PET would be more appropriate. So it's not entirely clear how you handle this, and insurance actually becomes an issue in general. But it really depends on what type of therapy the patient's receiving and whether or not you're considering PRRT, in my mind.
That's absolutely correct. And if I may say here, as a follow-up thought about it, is especially at the NIH, we're able to do both by the same time. We're a research institution, and we're trying to answer a specific research question. But I understand that on my natural history study for neuroendocrine neoplasms, I also realize that insurance is becoming a limiting factor. And usually, as Dr. Hope said, that if we think that the patient may benefit from Lutathera treatment, yes, I will decide, okay, gallium scan could be the best scan to do in these situations. Now, for the poorly differentiated neuroendocrine tumors, we know that these patients, they don't express somatostatin receptors. So in those situations, FDG PET scan will be the imaging study of choice. Something else I want to add here is as well for the pheochromocytomas and paragangliomas, because that's another disease I treat a lot at the NIH, is I went to do MIVG versus a gallium scan. And again, it's, as Dr. Hope says, about the limiting factors, what insurance can cover in this situation, and then decide what is the next treatment option for these patients as well.
So Dr. Hope, I know that we've talked a lot about gallium-68 and the advantages, and in some senses we've almost built it up that we've called this the gold standard, or some people have. But there are times when other imaging, much as you did in your presentation, is the right imaging. So is there really a gold standard for NETs, or is it the right scan for the right treatment, or for the right patient at the right time?
You could never disagree with that statement, right? It is always the right scan for the right person at the right time, by definition. But yes, I mean, looking at the phrasing of the question, I would generally say that disease location and pace really dictate the type of imaging study that should be done. So if your disease is in the liver, hepatobiliary phase MRI is really the best way to follow that. If it's mesenteric disease or peritoneal disease, CT scan is going to be the best way. If it's lung, you're going to want to be doing CT. If you're bone dominant, then dotatate PET becomes consistent with what you'd want to do. So yeah, it really has to be tailored to each individual patient, where the disease is, how fast the disease is growing. All of that has to be taken into account.
So we talked a little bit. I'm going to go to clinical trials right now and talk a little bit about the clinical trial data we had. And there's a few questions about when would you consider the alpha trial, whether if it's early on in your disease history or if it's post having Lutathera. I know you're not either of you are PIs on that trial, but when do you think about sending people to look at that trial?
So they completed enrollment in their phase 1, 2, and so really it's going to depend a lot on the inclusion criteria for their next trial as to what stage of disease would be allowed to be enrolled in that trial. As a general rule of thumb, given how well Lutathera is tolerated and how well patients benefit from that treatment, I probably wouldn't send early on in the course of disease, post sandostatin progression and, a typical behaving small bowel or pancreatic neuroendocrine tumor to get an alpha PRT. I would probably prioritize patients who are progressing post lutetium dotatate or who are having other factors that are sort of more negative in terms of predicting their response to PRT, if that makes sense.
Absolutely. And Dr. Del Rivera, I know that you spoke about the natural history trial. Would you like to talk about, I know that it's still open, but how would people reach you again?
Right. Yes, thank you so much. And I'm very excited about this protocol natural history study for neuroendocrine neoplasm, because one of the things that we wanted to understand about this natural history is a longitudinal study, meaning we're following patients long term. We also, by that, wanted to understand more about the biology of the disease. We wanted to determine if we can do screening guidelines for these neuroendocrine tumors. So the best way is to contact me directly, and I hope there is a way for patients to receive my email and my contact information, so that way I can determine eligibility for these patients. We are including patients all over the world, not only in the United States, but other part of the world. We're including all patients. One of the good things about this trial is that we're able to enroll patients remotely, so they don't need to come to the NIH to be seen. We can provide an expert opinion. We have a tumor board. We have a multidisciplinary NET team at the NIH, and we can provide an opinion based on all the information that is sent to us. And again, these patients don't need to come to the NIH. Another thing that I want to mention here is because since this is an NIH-funded protocol, is that everything that we do is free of cost, and we don't involve any of the insurance company to gather all this information. At the same time, if we decide that the patient could benefit from a visit to the NIH, we also pay for travel as well to come to the NIH.
One of the things in Dr. Pata's talk when we were talking about the upcoming LungNet trial is whether this type of trial was a registration trial. And Dr. Hope, since you're working on that trial, can you explain what the difference is between a registration trial and a non-registration trial?
Yeah, so it's a gray area. So let's just be clear in that. So technically, a registration trial is a trial that you are running in order to add an indication to a label or to get a drug initially approved. So for example, the NETTER-1 trial is a registration trial to get lutetium-177 dotatate approved. If you wanted to add a bronchial neuroendocrine tumors or bronchial carcinoids to the label, add it to the lutetium-177 dotatate label, that would be called a registration trial. Now, this trial that we're running is technically a phase 2 study, so it has a little over 100 patients that are going to be enrolled, and we did not meet with the FDA to discuss whether or not this would be adequate for registration. Now, at the same time, we believe that the results of the trial may actually be able to be used to add to the label the indication of bronchial carcinoids. Now, that being said, it still has significant value, because if you do run a trial like this and it doesn't change the label, guidelines, NCCN guidelines, and other guidelines will incorporate the results of this study and allow in essence, enforce insurance companies to cover this. So, for example, even Medicare will actually go sometimes by NCCN guidelines rather than by the label itself. So the gray area is both that this trial may or may not lead to a label change for lutetium dotate. And then secondly, the hope is even if it doesn't lead to a label change, it will still lead to a practice change. And I think it's really important because this question about everolimus versus PRT is something we struggle with not just in bronchial carcinoids. So to understand differences in efficacy, et cetera, with everolimus versus lutetium dotate will be really important for patients in the community moving forward.
And, following up, because I'm on a clinical trial bent here, when we talk about these trials, whether it's a registration or a phase 2, and depending on what we're looking at, the numbers are different. But in most NET trials, what are the types of numbers that are required to do a trial?
Well, so in this situation, this is our experience at the NIH. We have a statistician that is working very closely with us, and the number is also determined. But what is the published data documented for response, and how many patients were included in order to achieve that response? Based on that, we kind of have a calculation of these patients, how many patients needs to be involved in order to meet our endpoint, whether it's progression-free survival, overall survival. So now, considering that neuroendocrine tumors is relatively a rare disease, I think that sometimes in terms of clinical trial developments, in order to include less patients or in order to have or achieve our endpoint, what we do is a proof of concept in the sense that we may need less patients in order to achieve or meet our endpoint. And then from there, the idea is that with that, we can then have a larger trial that will allow for patients also to meet the endpoint and then to get the FDA to get approval and have another indication for these patients that insurance can pay for it. I don't know if that answered the question.
But in our world, in the NET worlds, these are several hundred-person trials if they're going towards registration, not several thousand-person trials, because of the rare disease and the number of people we have. And so I think that was the point that they were asking. Mm-hmm. And I know there is a trial, is there Lutathera or PRT for high grades? And I know that both of you may have trials open that work on higher grade NETs. And do you want to discuss that for a second?
Yeah, so interestingly enough, the label for lutetium dotate actually includes G3 tumors. It doesn't actually delineate G1, G2 versus G3. So it actually is technically approved by the FDA to be used in G3 neuroendocrine tumors. I think there's definitely a role for it in well-differentiated G3 neuroendocrine tumors. Obviously, there's limited to no role in poorly differentiated G3 neuroendocrine tumors. We're very cautious using it in well-differentiated G3s in the sense of I really think about the pace of disease of a patient coming in as to whether or not they would be a good candidate. So the faster the pace, the more aggressive they are, more likely they might benefit from chemotherapy. If it's a slower pace disease, the Ki-67 is over 20, then maybe PRT would be more appropriate. Now, we do have a study where we have a combination of pembrolizumab, which is a immunotherapy that belongs to obviously PD-L1, in combination with PRT in order to see if that combination is more effective in well-differentiated G3 neuroendocrine tumors.
And also, I just would like to add that also for our NIH Lutathera olaparib trial, we're also including G3 tumors. So that's from grade 1 to grade 3 neuroendocrine tumors as well.
So this is back to Dr. Della Rovera, and Dr. Hope, you can comment on this, but Dr. Della Rovera, you have two studies open, one in the paraphios, one that you're talking with the PARP inhibitor. When do people start showing their data, when people can start knowing that things are going on in this area?
Let's talk about, because there's two trials, so let's discuss first the PRT olaparib trial. So that trial is only available to the NIH. The idea is we actually, for that trial, the number of patients is about 36 patients, and then after that we go to a proof of concept phase 2 study, and we see any activity. The idea is that we wanted to do Lutathera versus Lutathera and olaparib, and we're hoping that this will be more of a multi-center study. For now, we hope that after we enroll our first 36 patients for the phase 1 study, we should be able to publish that data and at least see if there is any activity and the results that will lead to our phase 2 study. Now, for the pheochromocytomas and paragangliomas, we actually we just amended that protocol. Dr. Franklin is a PI of the study, and Dr. Hope is also going to be another PI on a UCSF and for pheochromocytomas and paragangliomas. And the idea is that there are going to be more of a 2 or 3 centers that will be involved on this trial to accrue more patients for the studies. UCSF, UPenn, and NIH will be the centers that will have this trial open.
This is back to Dr. Del Rivera and figuring out when can you have surgery pre or post PRT, or does PRT, can that lead to a surgical outcome?
Yeah, that's a very good question, and I would like to know the thoughts of Dr. Hope. But then, so we're talking about PRT, if there's any benefit of giving PRT prior surgery or after surgery. And the thing is, we don't have enough data. I think there has been some centers that has been used PRT prior surgery to see if that shrink the tumor, and that will be easier to do surgery. As well, there has been some centers that has used PRT after the surgery, if there is any evidence of disease after they have the bulk do the surgery, and there has been some benefit. However, in order to really determine if there is any benefit in survival, progression-free survival, overall survival response rate, I think it's important to have more of a prospective study, clinical trial, randomized study in order to determine what is the benefit. I think a lot of this is based on experience on different centers. Some centers are more aggressive in doing surgery, some other centers are more of giving PRT. I think this is an area that we need to learn more about it. I think that depending on the expertise of each center about what doing surgical intervention, but I don't think personally we have enough information to really determine what would be the best survival of this treatment. What do you think, Dr. Hope?
Yeah, I mean, this is a hard question, and to a certain extent, it goes back to some of what we were talking about before, which is it really depends on the individual patient. My general approach to patients, and this is obviously a team approach with our surgeon and Dr. Bergslin, our medical oncologist, is if you can undergo surgery and it potentially is beneficial, you can significantly debulk the amount of tumor or remove a primary, particularly in a small bowel that might be causing obstruction. That should always happen first. So depending on the distribution of disease and the potential success of the therapy, of the surgery, one should consider surgery first. A second thing to keep in mind is that PRT, as we've heard in many of the talks today, doesn't shrink tumor all that much. So to consider PRT as a neoadjuvant treatment to actually debulk tumor prior to surgery and make surgery more likely to be successful, I'm a little bit cautious about that because it doesn't really shrink tumor significantly in order to be effective. And then the third thing I would say is that this is a hypothesis, and I would like to test it in a trial setting. I'm not sure we'll ever get there. But if you think about, if you have tumor volume, a lot of tumor volume, your radioactivity from PRT is evenly distributed throughout the tumor volume. If you can debulk half of that, now the PRT is distributed over half the volume. So you can increase the dose to the residual tumor if you do surgery first. So there's theoretically a potential benefit of debulking surgically or by using liver-directed therapy prior to PRT in order to make PRT more effective. Again, as Dr. Del Rivera said, this hasn't been proven or anything, but those are sort of what I take into account when I think about surgery versus PRT.
One of the things that as a patient we talk about is limiting our pathways. Does PRT limit any treatment pathways, or are there other treatments that limit pathways into PRT that we should be aware of? Dr. Hope, I'll start with you and then follow with Dr. Del Rivera, and we'll do 1 or 2 more questions after this. You guys have been incredibly gracious with your time.
No problem. You can go on and on. I'm happy to take. I love these questions. It makes me.
Yeah,
all right.
Me too. You can
then I'll go on and on.
So the PRT toxicities that would prevent, I'm mainly thinking about bone marrow toxicity. If you injure someone's bone marrow and cause significant cytopenias, it's potential possible that you wouldn't be able to tolerate something like CAPE-10 moving forward. So there is, and it's not common in patients who get PRT to have persistent low blood counts, but that could be something that could prevent a patient from getting a subsequent therapy. The other thing coming into PRT that could be a problem is if you have significant liver toxicity. So if you've undergone multiple radioembolizations, liver target therapies, and your LFTs are very high, and maybe you start developing ascites, I might not want to treat that patient with PRT for fear of putting them into fulminant liver failure. So those are the two sort of before maybe liver targeted therapies, afterwards bone marrow injury preventing other types of therapies that might cause bone marrow injury. But Dr. Del Rivera, I'm sure you have other issues that we could have.
Actually, yes. I mean, I completely agree with you. But one thing that I want to mention here is that even if a patient receives PRT, that doesn't exclude them to receive any of the treatments. But again, as long as Dr. Hope said, the bone marrow, we take into account there is any bone marrow toxicity, because as Dr. Hope said, there is a significant bone marrow toxicity, maybe Captain could not be the next option. And again, it's a very personalized treatment for each patient. But one thing to keep in mind is, like, even if patient has received PRT, that wouldn't exclude them for other treatments. And I think that's important to keep in mind. But again, we need to determine, what the toxicity of the patient that have received for other treatments in order to give the next treatment.
So, Dr. Hope, I get this a lot, and when I went back at the NRC to talk about radiation safety, there was no conversation about pets. And what about our pet family members? What do we do with them during PRT?
You use your pets to make you happy. Don't kick them out of the house. Keep them with you and enjoy them. So a couple points about pets. So first, pets don't live 100 years, right? They live 15, 20 years, depending on how healthy your dog is or your cat, et cetera. And so if you think about the timeline it takes to develop a secondary malignancy, it's quite a long time. So it's unclear to me whether or not there's even real potential effects. Secondly, I think from the talk I gave, hopefully, the takeaway was that the dose emitted from a patient in the setting of PRT is quite low. So your pet would have to be sitting on your lap for days straight to have any significant dose deposited in them. So overall, I think it's very safe to have a pet at home, and I'm not worried about it. So please keep your pets around and keep them in your life.
Coming back to PRT and combinations, both you have trials with combinations, and certainly Dr. Hicks talked about CAP-TEM as a potential use, although he certainly limited that to those who had higher grade disease. When do you use them, or how do you decide to enter in a trial to use them? I think that's the big question, because it's not just using them for everyone. I think is what is that right moment in time to go look at that? And I know there's no absolutes.
Yes.
This is the Dr. Del Rivera question.
So the question about radiosensitizer is a very good question, but again, I don't think we have all the answers right now. So, and the reason why is because we're still doing preclinical studies. We're still doing at the NIH. We just opened the trial with PRT on olaparib. And the reason why we're giving olaparib is as a radiosensitizer. I think, as I say on my talk earlier, the hypothesis is by giving olaparib could potentiate the effect of Lutathera, and our endpoint is actually to see if maybe by doing that could shrink the tumor more. And as Dr. Hope said, we know that the Lutathera doesn't have this very robust response in the sense that it can shrink the tumor. So we're trying to determine if by giving olaparib could achieve that endpoint. Now, in regards to immunotherapy is another one in combination with PRT. Why we want to give immunotherapy? Because immunotherapy kind of like stimulates the immune response, and as well with PRT, if you give PRT, that can also stimulate the immune response, making immunotherapy more efficacious, and that's a rationale why we wanted to give these combinations. I think there is still a lot of we still need to learn about this. I think that, the NIH and UCSF are the only ones that, my understanding, that have these trials with combination in order to determine if we can make PRT more effective. But again, this has to be in the setting of a clinical trial to understand what is efficacy. I don't think none of them has been given outside of a clinical trial.
We also hear from patients, especially whose platelets or red blood cells go down, what type of supplements I can do to stay on trial or to recover faster. is there any such a thing, or are we, is there any supplement that would be better while we're under trial, or should we actually stop different supplements because of interactions?
Yes. So basically, whenever a patient is enrolled in a clinical trial, we actually advise not to take any extra supplements unless it's really needed. The reason why is because, especially in the setting of a clinical trial, everything that you take, any supplements, any vitamins, anything is metabolized through the liver. So we wanted to understand, especially if we're having a patient enrolled in a clinical trial, that there is no any other drugs that are interfering with the efficacy of the treatment that we wanted to study, or if there is an interaction. So we usually don't recommend any supplements unless it's really needed. Vitamin D, I think it's okay to take, but otherwise any other supplements that I could add, unless it's really necessary, I don't think I can add anything more supplements. If the patient has iron deficiency anemia, yes, we can give iron supplements, and that's necessary. But any other supplement that is not necessary, I will definitely not include it in the settings of a clinical trial.
Supplements work when you have a low count that's due to a deficiency, right? And when you have cytopenias or low counts in the setting of PRRT, it's caused by radiation, right? Radiation's injuring the cells that are making, your red blood cells. So you don't have iron deficiency anemia, such as Dr. Del Rivera said. So in general, supplements aren't going to have as big of an effect. It's really just waiting for the radiation to go away and have those cells come back, if that makes sense.
Oh, yes, Dr. Topin, I'm sorry. I'm just giving an example. This is something that personally in the setting of a clinical trial, we don't really recommend anything that is not needed, if that's maybe an easy answer.
And Tom, I'm going to ask, this is actually both for Dr. Hope and Dr. Del Rivera. The last question, I'm going to generalize this as well. This is a lung med who's allergic to CT contrast dye, but what is the best imaging? But also there's a series of about 4 or 5 different questions that say I'm allergic to contrast, or I'm allergic. How do we monitor them, and what's the best way to go do this? And we'll wrap that up with, what do you do with people who are allergic to different types of imaging agents?
We have a trend here in our conversations, which is everything ends up being very patient specific, right? So you really need to take into account that individual patient. So the history I'm given here is a person who had a bronchial carcinoid and had surgery and is 4 years out. Now, if the patient has had no evidence of disease over time, I think a non-contrast CT of the chest would be very valuable. If there's evidence of disease and there's metastatic disease that's present, then you'd want to start considering something like a gallium somatostatin receptor PET, right? So it really depends on where the disease is and what the location of the disease is. If it's in the liver, then the patient may be able to get gadolinium contrast, and so could get an MRI with a non-contrast of the chest, CT of the chest. So again, it's very patient specific, and you really need to think about the extent of disease, location of disease, and then where the patient's at in their course of treatment.
I agree with Dr. Hope. The only thing is that I'm not a radiologist, I'm an oncologist, but some things that I, with my patients is that I do tend to order what we call a dry CT, meaning without contrast, and sometimes I'm able to see any other metastatic disease in the lungs. However, if we wanted to see more of the parenchymal disease, I think sometimes IV contrast is better. But as Dr. Hope say, I think the gallium scan could definitely be helpful in these situations.
So once again, I want to thank both of you for taking parts of your Saturday afternoon, your Saturday morning to be here with me. And I want to thank all of our speakers for taking the time out. We've had talks from around the world today and from people we don't normally hear from. So again, thank you for your time. I want to thank our sponsors, Advanced Accelerator, Astellas Pharmaceutical, Blue Earth Diagnostics, ITM, Jubilant Radio Pharma, Progenics Pharmaceuticals. I'd like to thank the SNMMI for helping us put together. I'd like to thank Rich Tamayo, our producer, for managing all of our recordings and our live session here. And with that, enjoy the rest of your Saturday.